So aldosterone's job under normal circumstances is to help you regulate sodium and potassium balance. When you're dehydrated or when your blood pressure is low, aldosterone goes up and it tells your kidneys to hold on to sodium and hold on to water, and that's appropriate, and that's our system working correctly. But in primary aldosteronism, one or both of your adrenal glands start producing aldosterone on their own, independently, without waiting for a signal. So the sodium retention keeps going unchecked and you retain more water, and that makes your blood pressure go up and stay up. Not because of what you ate, but because of what your adrenal glands are doing around the clock. Now, this has flown under the radar for a long time because for years, primary aldosteronism was considered to be very rare. It was only something the doctor looked for if we had a constellation of low potassium on the blood work and high blood pressure. So that was the red flag. And if there was no low potassium, then there was no reason to look. But the data has shifted. There was a landmark study that actually contradicted that historical assumption that you only needed to worry about it if you had low potassium. In fact, 50 to 80% of people who were eventually diagnosed with primary aldosteronism actually had normal potassium level at presentation. So there would have been a lot of undiagnosed cases that would explain high blood pressure in otherwise healthy people. So what does that mean in practical terms? Well, if you look at the 2025 Endocrine Society guidelines, they recommend screening for primary hyperaldosteronism in everyone who has high blood pressure. And if you wanted to get screened for that, the test you want to ask your doctor for is called the aldosterone to renin ratio. Now, if that screen comes back positive, well, then your doctor will need to do some additional tests to confirm it, and more importantly, to figure out what's causing this. In some cases, it's just a small adenoma or a small tumor that sits on top of your adrenal glands that's just making excess aldosterone, which in that case, sometimes people may need surgery to remove that. And in some folks, it could be both of your adrenal glands, they're just overactive, like with a condition called bilateral adrenal hyperplasia, which in that case, that's usually managed by certain medications that specifically block excess aldosterone. So this would be medications like spironolactone or aldactone. Now, unfortunately, there isn't a one-size-fits-all nutritional plan I can give you here. What you eat and what you limit can look very different depending on what's actually driving that excess aldosterone production and how it's being treated. So the diet piece, which is usually the foundation of how we approach things, really has to work alongside the medical plan that your doctor puts together. Now, another thing that rarely comes up in blood pressure conversations, even though it has a direct mechanism connecting it to blood vessel damage and ultimately high blood pressure, and that is elevated homocysteine. And homocysteine is just an amino acid that forms as a normal byproduct when your body processes protein. And under normal circumstances, it doesn't hang around for too long. Your body converts it into other harmless compounds. But that conversion process requires B vitamins to work correctly, and specifically vitamin B12 and B6, which is pyridoxine, and B9, which is folate. And when those nutrients are low, and the most common of those would be low B12, well, that process slows down and homocysteine starts to build up in the bloodstream. And that creates a second layer of problems. And this is where the connection to blood pressure comes in. When homocysteine levels get too high, it becomes directly toxic to the endothelial lining, that thin layer of cells that lines the inside of your blood vessels. And this triggers inflammation and makes your arteries become stiff and inelastic, which all of that causes high blood pressure. And we see